Sorry for being a few minutes late. I had a long day at work, but even then I tried to join by 7 p.m. itself, but there were some connection problems from my side. So sorry for that. I'll share my screen.
Yes, you can start.
Okay. Okay, so once again, good evening to all. So we'll start this session, and I think it's the first time I'm taking a class for a group of oncologists, and I feel very happy for that. And oncologist means you will be dealing. You all are dealing with cancer pain patients. That means cancer patients. That means one of the most severe uh, pain conditions we can see in a hospital setting. So I think all of you might be already familiar with the basics of pain management and pain medications. And so this session is just an introduction. I'll be mostly focusing on pain mechanisms, the physiology part, even though it's very boring. That is the work which is entrusted upon me. And other than that, the assessment, different types of pain, opioids and non-opioids, neuropathic pain management, all this will be taken in the subsequent sessions that I understand that. So this will be just basically a very much an introduction to pain, how to approach a chronic pain patient. And I started my pain practice or pain education in Pallium, India. And after that, I did this 2-year fellowship in interventional pain management, that is mainly on non-cancer chronic pain from SDPGI Lucknow. And right now in KIMS Hospital, I am in charge of the non-cancer chronic pain actually. And Dr. Shali is taking in charge of the uh, cancer pain, but we both work together as a team. On an everyday basis, I also see malignancy patients, especially those with difficult pain. But these days, I practice more in non-cancer chronic pain. So, so today I'll be dealing with the definition of pain as well as palliative care, then the epidemiology of pain in cancer, then the classification, then the physiology and the pathophysiology. That is the area where I am going to focus the most, and then the management, the general principle, just the general principles of management. So the International Association for the Study of Pain, IASP, the latest definition which they updated in 2020 is, and pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. But we don't need such a long definition to understand what is pain. In the simpler words, or what I can say is, if there is one take home point from this class, that would be to believe the patient. Pain is what the patient says it hurts. And we should also understand the concept of total pain. So we know that in our OPDs, when the patient says we all are very busy in our OPDs, we have 5 minutes or maybe maximum 10 minutes for the patient. So what we understand from their the magnitude of pain from what they say, or what we are able to understand, is just the tip of the iceberg. There are so many factors contributing towards a total pain experience. So the physical pain means the pain caused by the cancer or the comorbid conditions that caused by treatment, and all this comes under the physical pain. The patient will have a lot of psychological problems like anxiety, depression, frustration. All this comes under the psychological domain. Then we have the spiritual domain. Why this is happening to me? The loss of faith in religion. All these things comes under spiritual. And social, he might have been the only breadwinner of the family. He lost his job. He lost his social role. He finds himself to be a burden for the family. And all these are the social concerns. So all these four domains contribute towards a total pain experience. So when the patient says, I am having pain, where you are having pain, we will ask that he'll say, I'm having neck pain. So if you're just focusing on that neck pain, this might be causing loss of, loss of sleep. He is not able to work, and all these problems are there. But if you're focusing just on neck pain and prescribing some analgesics for neck pain, we may not be able to get the perfect, the best outcome of that. So we have to address all these four domains to improve the quality of life. That is the most important word in palliative care, right? To improve the quality of life of patient and the family. But having said that, there is another phase to it, I can say, that sometimes this cancer pain patients, if they don't get enough relief, even after starting strong opioids, some of my colleagues, maybe doctors or nurses, some of them say, oh, it is psychological. Because 2 days back only, I revealed to my patient that it is, your disease is incurable. So this is psychological pain. So I personally feel that it should not be brushed off like that. Physical pain, we have to try to evaluate, explore which is causing the major concern. And when physical pain is there, nothing like that, hurts more than nothing hurts more than physical pain. So it is, even though we understand all these four domains are there, I don't agree with the concept that when, if you're not getting relief, you have to revisit your diagnosis. I don't agree with the concept that to just brush it off saying that it is psychological. Okay, you have to revisit the diagnosis. You might have missed something. You have to revisit the diagnosis, readjust your medications, explore newer options for treatment. Then you may get a better relief for the patient. Now, what is palliative care? So, palliative care is an approach that improves the quality of life of patients and families facing problems associated with life-threatening illness. And how do we improve the quality of life? Through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Again, a long definition, but in simpler words, we just have to improve the quality of life of the patient as well as the family facing a life-threatening illness. And how do we do that? Timely assessment and correction of the physical, psychological, social, and the spiritual factors. So other principles of palliative care and other in-depth, the discussion of palliative care will come in the next classes, I hope so. So we'll more focus on pain today. So we'll go to the epidemiology of pain in cancer. So can any one of you guess, because I would like my class to be interactive, because otherwise after 15 minutes you will sleep and after 30 minutes I will start sleeping. So can anybody of you guess how much will be the percentage of pain, severe pain in a cancer patient, the incidence of severe pain? Let's say in advanced cases, metastatic cases, what will be roughly the incidence or prevalence of severe pain, moderate to severe pain, 50%, 30%, 70%? Do you have any guess on that?
More than 70%.
Yes, sir, it's very correct. So this is the incidence of moderate to severe pain in cancer. So you can see that 70% is the incidence in advanced malignancies. 70% is the incidence of moderate to severe pain. We are not even talking about the mild pain, moderate to severe pain. And all stages combined together, at least 50% patients will have moderate to severe pain. Now, if you look at the prevalence, again, During cancer treatment, around 55%. After curative treatment also, there is around 40% because surgery related, chemo and radiation related, non-cancer pain will be maybe there after the cancer treatment. Then, so this is the prevalence. Again, the moderate to severe pain prevalence in all stages together is around 40%. Now, are we treating the pain adequately? So this study conducted in 2018, they found out that mild pain, we are giving adequate pain relief in 50% cases. In moderate pain, we are giving adequate pain relief only in around 20%. 80% patients are left more or less untreated. Okay. And when it comes to severe pain, we are giving adequate pain relief only in around 5.7%. Our 94%, so severe pain, especially if you see in an advanced malignancy patient, sometimes we don't have much to offer other than pain relief. But still, almost 95% cases, we are not treating the pain properly. We are under treating. So can we make a change to that? So that is, I think, the whole intention of all this education training programs, to assess the pain better, to have a more understanding attitude towards pain, to take pain more seriously. At least at some point of time, we have to understand that, okay, there is a limit to what we can offer in terms of curative treatment. If at all we have so many options more to explore in curative treatment, whatever we try, what is the use if the patient is not having adequate pain relief? So that is the whole intention of this kind of education programs. Now, coming to the classification of pain, so we have based on time acute pain and chronic pain. Acute, we mostly in cancer we deal with chronic pain patients. Then we have nociceptive pain, neuropathic pain, and nociplastic pain. So what is nociceptive pain? The pain when the tissue nociceptors get activated after a noxious stimuli. What is neuropathic pain? It is a lesion or disease of the nervous system itself. So anybody have any guess about what is this nociplastic pain? This is a newer term coined by IASP, I think in 2020 or something. So anybody has any guess regarding what is this nociplastic pain? Okay, so basically nociplastic pain means centrally amplified pain syndromes. That is, there is no identifiable tissue nociceptor activation. There is no identifiable lesion or disease of the nervous system, but the patient is having pain. So this is basically an altered sensory processing or altered pain processing. So do you know any condition which is associated with an altered pain processing, amplified pain processing? Now it is more clear, I think.
Phantom limb.
Phantom limb, fibromyalgia. Okay, fibromyalgia, chronic post-surgical pain, atypical facial pain. There are so many conditions. Then irritable bowel syndrome. So all these conditions, there is no identifiable cause, but definitely it is not a completely a psychiatric problem also. It is basically a problem with the pain pathways, altered pain processing. So that is known as nociplastic pain. Now, coming to acute versus chronic pain. So 54-year-old gentleman, a case of CA lung with bone mets. He comes with a pathological fracture of the right humerus. The patient grimaces in pain, has tachycardia and sweating. He says that he is in severe pain. Whereas we have another gentleman, 60-year-old gentleman, a case of carcinoma head of the pancreas on chemotherapy for the past 4 months. Patient says that he is in severe pain, but he does not appear to be in distress. He looks tired, gloomy, and has decreased appetite and sleep. So what I see in my wards, especially with our nursing staff, everyone believes that this patient is in pain because he has tachycardia, he is sweating, he is in distress, so he is in severe pain because this is an acute pain. Whereas chronic pain, the patient is already living with this pain for the last few months. There are so many adaptive mechanisms going on. So he may not have tachycardia, he may not have sweating, he may not appear to be in distress. But in both cases, if you look at the pain score, this is also 10 out of 10, but this is also 10 out of 10. But what happens in our wards is This is more considered as an invisible illness. So nobody understands. Especially this happens after you give start on opioids, strong opioids or NSAIDs. You give that, but the patient says, "I'm still in pain." So nobody understands that, and often it is all said to be the problem is in your head. So that is a problem with chronic pain. Nobody believes at times that the patient is in severe pain. Now, why this happens is chronic pain has got an ill-defined onset and a prolonged fluctuating course. Overt pain behaviors like I already told, grimacing and sympathetic hyperactivity are typically absent, but vegetative signs like lassitude, sleep disturbance, anorexia will be present. Patient may not always appear to be in pain, and the only definitive way to determine the presence of pain is to obtain a verbal report from the patient. So I remember having a CA pancreas patient in our ward a few months back. So she was the same kind of situation. She was having severe pain, and at night she was started on fentanyl PCA, patient control analgesia. After trying everything else, she was started on fentanyl patient control analgesia, and she was in very high doses of fentanyl. And the morning when I reassessed, the patient was telling me, "Anyway, you're giving me so many injections. Why don't you give something and kill me? Because nothing is working for me." So for a minute, she was just 42-year-old, 45-year-old patient, a female patient, a mother of two. So for a minute, we also thought like, is it, some psychological factors contributing to her pain? Should we explore the total pain more? But then I felt that she was severely in distress. And uh, the all the staff nurses were telling the same thing, "Ma'am, she's having small children, so please arrange a psychological counseling for her." But then I told I'll try a celiac plexus block, because in CA pancreas neural compression may be there. Sometimes it will not, she will not benefit from anything else. So immediately, as an emergency, I took up the patient for a celiac plexus block. She got around 80% relief, and she was discharged the next day. So if we have thought that that was psychological, it was actually a mistake from our side. It is a mistake in our understanding. So chronic pain, it can appear like both. Patient may be in severe distress, not responding to the strongest opioids available, or sometimes the patients may be in severe pain, but they may not appear to be in that kind of a distress. But the basic agenda or our basic principle should be to always and always believe the patient unless otherwise proved. So believe your patient, treat early and treat well. That should be our motto. Now coming to the nociceptive versus neuropathic pain, I already explained what is nociceptive and what is neuropathic. Now, again, this is important. When a patient is sitting in your OPD and complaining of pain, just writing in the document, patient is having pain. The pain score is 5/10. This is not enough. We should try to identify whether it is nociceptive or neuropathic, because that changes the way of management. The nociceptive pain will be, the patient will be having throbbing, aching, catching kind of pain, whereas neuropathic, burning, shooting, scalding kind of burning, tingling, numbness. So an easy scale that you can use in your OPD is DN4, Dollar Neuropathic 4 Questionnaire. So you can take a printout of that and keep it in your OPD, DN4. So before the patient enter the OPD, I guess that almost all of you will have some waiting time. So you can give the questionnaire to this patient along with the any other questionnaire you are already using for marking the site of pain. You can give this DN4 question. It's a very useful tool, and ask the patient to mark that. So if the DN4 score is more than 4 out of 10, you will know that the patient is predominantly having a neuropathic pain. So can anybody tell me what is, I told the management changes. So what is the difference in management between the nociceptive pain and neuropathic pain? I know that everybody knows this, but just the class to be interactive and avoid sleeping problems, I'm asking this. What is the difference in management, nociceptive and neuropathic pain? Because if a patient is sitting in your OPD and complaining of pain, so is it important that you assess the character of pain and manage accordingly?
Yes, there are some drugs which act specifically for nerve injury or nerve compression. and there are certain drugs which specifically strong opioids which may not be effective in case of neuropathic pain, but there are some
Yes.
drugs which specifically targeted for such things. So categorizing between those two pains is important along with opioids.
Yes, yes, very good. So basically, the why I'm have put a slide is this: response to analgesics, especially opioids. So very often this happens in our wards, that even after giving the strong opioids, the patient is not having pain relief. Uh, there is they may point towards malingering, functional, all these kind of things. But we should know that only nociceptive pain responds to our traditional analgesics like NSAIDs or opioids. Neuropathic pain has poor response to these NSAIDs, opioids. So we have to start them on anti-neuropathic drugs. We'll come to that later. And there are some opioids or some drugs, analgesics with neuropathic pain action. In opioids, most importantly, it is for tramadol, tapentadol, methadone, buprenorphine. So these are some of the opioids with some action on neuropathic pain. So you have to start the patient on one of these opioids. Okay, most commonly I start on tramadol. Along with that, you have to start on an anti-neuropathic agent. So unless you identify this character, and if you just write paracetamol or sometimes even morphine, that is not going to help the patient. Now, so then I come to the next portion, which is physiology and pathophysiology of pain. So this is very complex and boring also, I know that. But I always tell when I take this class that unless we know the physiology and pathophysiology, treating pain will be like this. Okay. So each person will think that this is the cause of pain. One person will think it is psychological. Another person will think it is functional. I mean, malingering. Another person will think it is neuropathic. So we should understand where in the pain processing it has gone wrong. Then only we will be able to give the optimal management for the patient. So in simple terms, so I will be dealing a little bit in detail here because the rest of the class like management, palliative care principles and everything will be dealt in detail in the next classes. But physiology and pathophysiology and the basic mechanisms, how where you have to target for pain management. So that is dealt only in this class. So I'll be going with a little detail, but you need not know everything in that detail. So if you are not able to follow me, that's not a problem. If you have any doubts, you can ask me at the um, when we finish the class. So in simple terms, this is the pain pathway. It starts from the peripheral nerve. So the free endings of this peripheral nerve, these are known as nociceptors. So they carry the information, and the primary neurons, the cell bodies, are located in the dorsal root ganglion. From there, these dorsal root ganglion are pseudo-unipolar neurons, and their axons bifurcate into two. One axon carries the information from the periphery, one part of the axon, and then the second part of the axon, it gives the information to the dorsal horn of the spinal cord. From there, it is projected to the brain. So the dorsal horn neurons are also known as projection neurons. These are the primary neurons, and the second order neurons in the spinal cord, dorsal horn, they are known as the projection neurons. They project to the cortex, the brain. So these are the four components of the pain pathway. Transduction means a noxious stimuli is converted to an impulse. Then it is transmitted. Then some modulation happens here that I will come to that later. And then ultimately it is perceived in the cortex. Transduction, transmission, modulation, and perception. Now, this pathway, as you all know, is a spinothalamic tract or the lateral pain pathway. So this is the most important pathway that carry the pain sensation. So the A delta and C fibers, they carry the pain from the periphery. As I told, here is a dorsal root ganglion coming to the dorsal horn. They cross to the opposite side, then they ascend, give some inputs on the way to the reticular formation, periaquedural gray, etc. Then the VPL, ventropostrolateral nucleus of the thalamus, VPL, and from there to the sensory cortex. This is spinothalamic tract. Are there any other ascending tracts for pain? Yes, there are. So basically the other one, spinothalamic tract, it deals with the sensory discriminatory component, that is severity of pain, location of pain. All this we perceive with the help of spinothalamic tract. Whereas there are some medial, that is other one was lateral pain pathway. There are some medial pain pathways like spino-reticular, spino-limbic. So this shown in green are the spino-reticular and the spino-limbic pathway. They also give inputs to reticular formation, periaqueductal gray matter, and they relay in VPM, not VPL, the ventropostromedial nucleus of the thalamus and the intralaminar nucleus of thalamus. From there, they project to other parts of the cortex like limbic system, insula, prefrontal, and cingulate cortex. So where they project to the cortex is slightly different from the lateral pain pathway. So the importance of these pathways, these medial pain pathways, is it deals with emotions, autonomic responses, and most importantly, modulation of pain. So the first one, the lateral pain pathway, spinothalamic tract, that deals with knowing the location of pain, the severity of pain, whereas the medial pain pathway, spinolimbic, spinoreticular, they deal with the emotional and autonomic component, and again, the most importantly, they deal with modulation of pain. So my question is, if the stimulus remained constant, that is any stimulus which is causing pain, if the stimulus remained constant over time, what happens to the pain? Does it remain constant, decrease, or increase? Anybody? Over time, does the pain remain constant, decrease, or increase? What do you see in your CA patients? Even if the stimulus remain constant. Okay, actually, most of the time we see that the pain increases over time. So do you know why this happens? When the stimulus remain constant, even then the pain increases over time. This is because of something known as a modulation of pain, and most of the time this happens over when pain is left untreated or not properly treated for a long period of time. This happens. Even touch hurts, and this is known as excitatory modulation or sensitization. So the most important word in any pain class or any class that deals with pain pathways and processing is sensitization, because if we don't know this, we may not be able to give the best outcome to the patient. Then the pain is much better now. This is known as inhibitory modulation. So we will be talking mostly about sensitization. Then only we will be able to know how to counteract this sensitization, how to attack. So what happens in the event of sensitization? So your nauseous stimuli is constant, but somehow we fail to address it correctly. We fail to treat it correctly. The pain is left untreated for some time. What changes happen in the periphery as well as in the dorsal horn of the spinal cord? So what happens in the periphery, that is known as peripheral sensitization. So only one word you need to remember here. This is known as inflammatory soup. Okay. Whenever there is an injury, a lot of mediators are released like histamine, prostaglandins from the mast cells and neutrophils, histamine, prostaglandin, bradykinin, ATP. So many inflammatory mediators are released. And this inflammatory soup, what does that do? That sensitizes this peripheral nociceptors. Okay. So what happens is, with a low, they will have these nociceptors, they will have a low threshold for stimulation. More sleeping nociceptors will be recruited. For any given stimulus from the periphery, the response will be more. There will be an amplified response. And sometimes in case of nerve injury, they may behave spontaneous activity also. They may behave erratically. They will start spontaneous firing also from the nerve endings. So all these together known as peripheral sensitization. So for any given stimuli, there is an amplified response from the peripheral nerve ending. So what is the net result of that? For a noxious stimuli, there is aggravated response, which is known as primary hyperalgesia. Okay, so this is very important, this term, primary hyperalgesia. In the same site where there is injury or where there is problem, if you give a noxious stimuli, the same stimuli will produce an amplified response. That is primary hyperalgesia. Now, in the next slide, we'll come to know what is secondary hyperalgesia. Now, how we can prevent this? One is you attack here. You target the prostaglandins because that is one important component of inflammatory soup. So how do we attack this prostaglandins? What is the drug that inhibit the production of prostaglandins? NSAIDs. Okay. Second target is here. We stop the nerve conduction. So what? How do we do that? With the help of local anesthetic nerve blocks. So the peripheral sensitization to some extent can be targeted by using NSAIDs and local anesthetics. Okay. Now we come to the central sensitization. So don't worry, I'm not going to teach all these things. You know, one receptor which is attributed so much, maximum in the event of central sensitization, that is in the dorsal horn also. Now the neurons become hyperexcitable. Earlier that happens with the peripheral nerve ending. Now this happens in the dorsal horn. The projection neurons become hyperexcitable. And one receptor that is very much attributed for that is our NMDA receptors. So that is the role of NMDA antagonist ketamine in attacking this central sensitization. Especially, I don't know if we have surgical oncologists here. If your patients are posted for oncological surgeries like breast surgery or sometimes amputation and all, now we say that this perioperative ketamine infusion has a role in prevention of chronic postoperative pain. As somebody told in the beginning, amputation is associated with phantom limb pain. Mastectomy is also associated with phantom limb pain, chronic post-surgical pain. So all these can be prevented to some extent by giving perioperative ketamine infusion. So there is some evidence for that. Then another area we can block is this one. These are the calcium receptors, okay? Voltage gated calcium channels. So calcium enters through this and causes a release of neurotransmitters. So how do we block this voltage gated calcium channels? Through gabapentinoids, pregabalin, gabapentin. So in any chronic pain, maybe it is cancer pain or non-cancer pain, whenever there is a lot of sensitization component, there is a point in adding pregabalin or gabapentin to your analgesic regimen. Okay, that definitely gives some benefit by attacking this sensitization. Now, the third processes we can attack here, which are our sodium channel blockers, because the nerve conduction is possible only through the sodium channel. So lignocaine and oxcarb, sodium channel blockers, act in this fashion. And then finally, our COX-2 and prostaglandins causes excess release of neurotransmitters from the preganglionic neurons. So how can we block COX-2 and prostaglandins? Already I have told that COX inhibitors. So they have a role in peripheral as well as central sensitization, NSAIDs. So this is why I told that understanding where is the problem will help us to decide which drug we can start, which drug will help the patient. So that is why understanding physiology or pathophysiology is very important. Otherwise, we'll be just blindly something like of beating around the bush. Now, there are so many other mechanisms of central sensitization. We will not go to that. But what is the end result of the central sensitization? The dorsal horn neurons, they will show increased responsiveness. Then increases the receptive field. I'll come to that later if I have time. The receptive field means, suppose the pain is coming from the C6 dermatome. So earlier, the C6 projection neuron will respond only to the impulse coming from the C6 dermatome. Suppose if you are touching the C6 dermatome or if you are giving a noxious stimulator C6 dermatome, then only the C6 dorsal horn neuron will perceive that. But now what happens in the event of central sensitization is that from C5, and C7. The impulses from C5 and C7, then also the C7 projection neuron will perceive the pain. That is, the patient is having pain, suppose in C6 dermatome, but you are giving a nauseous stimuli in C5 dermatome, then also the patient perceives that as pain. So this is known as secondary hyperalgesia. That is pain away from the, you are giving nauseous stimuli away from the original site of injury or original site of pain. You are giving the nauseous impulse away from that site, but there is an aggravated response or amplified response to that nauseous stimuli. That is known as secondary hyperalgesia. So we just need to understand that that is happening because of this changes happening in the dorsal horn. And allodynia means, as I told in the previous slide, even touch becomes painful. The painful response to a non-noxious stimuli, you're just touching the patient, but there's a patient perceives that as pain. That is known as allodynia. So once the secondary hyperalgesia and allodynia develops, why this is important is, again, there is poor response to conventional analgesic measures. The pain becomes extremely challenging to treat. So this is known as neuroplasticity and wind-up phenomenon happening in the central nervous system. So this is a net summary of whatever I have told in sensitization. So peripheral nerve, what happens? So many sleeping nociceptors gets recruited. Their threshold for activation becomes less. For any given impulse, for any given stimuli, there will be an amplified response from the peripheral nerve. The same thing happens over time. Central sensitization, the changes happening in the dorsal horn, whatever it is, the net result is that the same thing happens here. The second order neurons that project the impulse to the cerebral cortex, they will become hyper-excitable. So this results in primary hyperalgesia. This results in secondary hyperalgesia and allodynia. So a cancer patient who's having this pain for, maybe he's suffering pain for 1 year. So this has happened in our wards, that some sisters, some staff nurses, they will tell us, Madam, this patient is not actually having pain, some other issue. Why? Why do you think so? Because I just, for putting cannula, I just went and touched the patient, then also he is screaming in pain. So this is because she doesn't know the concept of the secondary hyperalgesia and allodynia. That is, once the sensitization sets in, even touch becomes painful. So you should know that, then only you will be able to understand the patient's pain better and you will be able to treat the patient's pain better. So that is about my, coming to my question initially. With time, what happens? The area and intensity of pain increases and even touch becomes painful. Primary, secondary hyperalgesia and allodynia. Then inhibitory modulation, I'm not going to this in detail. Just like the excitatory modulation or sensitization, we have some descending pain pathways that helps to inhibit the pain or decrease the pain response. So you can go to that, take that later. Now, so our aim should be to intervene early, before the sensitization sets in, or recognize and target the sensitization if it has already set in. That is why we should maintain a more aggressive approach. Don't take pain for, it is, patient is having cancer, he will have some pain, right? That kind of an attitude, it will not, usually oncologists don't show that, but we have many junior doctors or staff nurses with that kind of, attitude towards pain. Patient is having cancer, he will have some pain. So we have bigger things to solve like that, but it is not like that. You should take a more aggressive approach for pain management and target pain or go for an optimal control before sensitization sets in. And management, I'm just touching the general principles. I'm not going to the pain management in detail. So we have a 4-step approach. It should be a multimodal and multidisciplinary pain management. We have to correct the correctable if there are any correctable factors like infection. And I remember a patient coming to Pallium India a few years back. He was having severe abdominal pain. I think a known case of CA pancreas only. He was having severe abdominal pain and he was referred from a corporate hospital to Pallium India for starting strong opioids because they don't have strong opioids there. But when we assess the patient's problem was he has not passed stools for the last 1 week or so. It was just constipation. But without assessing correctly, patient is having severe abdominal pain, say a pancreas or an abdominal malignancy with severe abdominal pain, go to another hospital, start on strong opioids. So it's not like that. We have to give attention to detail. Again, just because the patient is having cancer, the patient will have some pain. That is not the correct approach. Try to find out what is the pain generator, what is causing the pain. So if there is anything correctable, that we can correct that. And then we have non-pharmacological measures like physiotherapy, psychotherapy, and all the other ways to address the components of total pain. And pharmacological measures, depending on whether it is nociceptive or neuropathic, we will choose the correct drugs. And interventions, we have percutaneous and as well as surgical interventions for pain management. So this is a modified WHO analgesic ladder. They have added a step 4 for interventions, and also they made it bidirectional. Earlier it was unidirectional. Now it is bidirectional. As the pain increases, you can go up the ladder, and as the pain decreases, we can come down the ladder also. And around 71 to 76%, that is more than 75% patients will get adequate benefit if we manage using the WHO analgesic ladder. Nothing else is needed. But whether we address the pain correctly, that is another question. But once we address it, once we assess it correctly and take the correct measures, more than 70% patients will get benefit from the WHO analgesic ladder. I'm telling about the original ladder, not the interventions. The conventional ladder, 3-step ladder, 70% patients will get benefit from the conventional analgesic ladder itself. Now, this is another ladder for neuropathic pain management. So I'm not going in detail because you have a class on neuropathic pain later on. Then coming to interventional pain management for upper abdominal, because I told the pain management should be multimodal and multidisciplinary. Multimodal in the sense you have to target different mechanisms. You have to take the analgesics that target different mechanisms. And multidisciplinary means you have to use your interventional pain colleagues. You have to take help of physiotherapy departments, psychotherapy. So it should be multimodal and multidisciplinary. So for upper abdominal malignancies, we have celiac plexus neurolysis. And if you look at the evidence, this has got the maximum evidence, 2A plus, for cancer-related interventions. We have got for lower abdominal pelvic malignancies, we have superior hypogastric plexus, which has got a 2C plus evidence. And then for perineal and anorectal, we have ganglion nimba neurolysis and vertebroplasty, kyphoplasty for compression fractures, metastatic vertebral fractures. Now, what are the barriers to pain relief in our OPDs or in our inpatients? What are the barriers to pain relief? So one is the attitude towards pain. That is taken for granted, or there will be pain. We have, we have so many newer, so we have so many treatment modalities yet to explore. Pain we can take care of later. So that kind of an attitude towards pain. Then underestimation of pain. So how many of us estimate pain correctly? So in the next class, I think it's on assessment of pain. But this study, there are so many studies, but one study has quoted that whenever the patients rate their pain as moderate to severe, the oncology residents, they fail to appreciate severity in 73% of cases. Again, more than 70% cases, the severe pain was not assessed correctly. And there is another survey which found that discrepancy between the patient and physician evaluation of severity. Patient is saying I'm having severe pain, but the physician thinks, oh, this is not severe. The patient does not appear to be in any kind of distress. He is doing all his routine activities. So that means he is not in pain. So that discrepancy is a major factor or the most important barrier in giving adequate pain relief. Then another study, they found out that pain was underestimated in at least 24% patients, especially those with severe pain and female patients. So another important point that we have to take from this class is that we should revisit how we assess the pain, how we estimate the pain. So the third thing is misconceptions about painkillers. So recently, for a doctor, admitted in our hospital, I suggested a 48 to 72 hours course. So it was post-operative, a malignancy. He was operated for a malignancy, and I suggested a 48 hours, I mean 2 to 3 days course of NSAIDs. And the doctor was telling, no, I know that the NSAIDs are nephrotoxic. So I have to start him on strong opioids, even though the pain could have been just post-operative pain, could have been well managed with NSAIDs. So similarly, because a short course of NSAIDs in a patient who is otherwise does not have any risk factors, say a malnourished patient, poorly hydrated patients, poorly controlled diabetes mellitus. In those patients, definitely I will not start NSAIDs unless it is that indicated. But in an otherwise normal patient, there is no problem in giving a short course, maybe 3 days or 5 days. But there are some, blanket beliefs like I won't give NSAIDs. These are nephrotoxic, or I don't want NSAIDs. So these misconceptions are sometimes even a short course maybe need at that point of time to overcome the pain crisis. Just a short course NSAIDs will help. So that there are some misconceptions. Then again, this is a very important problem in our part of the world, that is opiophobia, unfounded fear of opioids. So I think after this class, I mean this whole education program, you will all be learning how to start on morphine, how to titrate morphine, how to change to other opioids. So I hope that all of you will be more confident in prescribing opioids, and you will not have this opiophobia if at all anybody is having. Then under prescription that leads to unnecessary suffering. So these are the most important barriers to pain relief. So I often tell to my staff nurses and residents that why pain is not taken seriously is that because nobody dies due to pain, right? Because if there is a tachypnea, tachycardia, or even urinary retention in our hospital, immediately they announce a code RRT or code blue, whatever it is. They will alert all the doctors. But in pain, that kind of an emergency response is not seen. Why? Because nobody dies due to pain. But what most of us don't understand is that many people die in pain, and even more worse is that many people live in pain. Okay, so how can we correct this is by giving an early referral and using a continuum of palliative care. Because now that this group of oncologists is already trained in pain management, I think you yourself can give a better pain management and opioids. But even if you don't have the access to strong opioids, or if you don't have that training, you should give an early otherwise also there should be an early referral to the palliative care. And very often patients think, many clinicians think, palliative care starts where the curative care ends. It is not like that. This is the major problem that I see in our pain palliative OPD also. That is, once the oncologist says, now you go to the palliative physician, the patient will feel devastated. Now everything else is over. I don't have any other options left. Now I am left to die. My oncologist is not going to take care of me anymore. He has told there's no need to come here. If you have any concerns, you can come. Otherwise, there's no need to come here. The patient will feel devastated. They will come near the palliative OPD, and very often they will not enter there. They will go just like that. So this is why we should start. You should give an early referral to palliative care. You should, from the very first visit itself, you should assess the patient's pain properly, and you should start them on analgesics. And from the very first visit itself, you can ask for a palliative care referral also. In our OPD, in our oncology department, this is being routinely done now. And that actually is a free visit also for the palliative care consultant. It has been designed like that. Otherwise, the patients will not go. So that should be made, mandatory, that in the first visit itself, you involve your palliative care physician also, so that there will be a smooth transition from the curative care to palliative care. The patients will not feel devastated when you send them for the palliative OPD. And also one very important thing is, when the patient's symptoms are taken care of well, they will cooperate better with your curative modalities like chemotherapy, radiotherapy, or surgery. They will cooperate better. Okay, the dropouts will be much less. So that is why you have to incorporate palliative care in your practice, as well as an early referral to a palliative care physician at the earliest, not when everything, all the curative options, and it is not like that. It should be from the beginning. So to conclude, this International Pain Summit in 2010, organized by IASP. So their conclusion was this: access to pain relief is a fundamental human right, or pain management itself is a basic human right. We cannot deny that, saying that the patient is having psychological problem or the patient is having issues at home. The pain management is a basic human right, and everyone should have access to that. And another take home point is, pain is what the patient says hurts, and we have to believe the patient regarding his or her pain. So with that, I conclude my session, and if you have any doubts, I'm willing to explore that. Thank you.
Thank you, Dr. Vineetha, for the excellent presentation. And the session is open for questions. Ma'am, regarding this tramadol, it's using for neuropathic pain. Are there any alternatives in case you have some issue with giving tramadol or patient have any seizure potential? Can you suggest anything?
Yes, tramadol. Other than that, we can give methadone. Methadone has got some action in neuropathic pain. Then we can give buprenorphine. Okay. So I gave actually buprenorphine in my either tramadol or buprenorphine, because I don't have methadone in my institution. In Pallium India, we have methadone, but in our institution, I don't have methadone. So if affordable patient, buprenorphine patch is expensive, but it has got very good relief in neuropathic pain. But if the patient is affordable, I give buprenorphine. If there is, otherwise, I'll go for tramadol.
Ma'am, the buprenorphine patch starts acting after 18 hours. So for the
Yes,
first 18 hours, will you give something else?
yes, yes.
Or
Yes, if there are no contraindications for tramadol, I give tramadol also along with buprenorphine just for the initial few 18 hours up to 1 day. Tramadol sometimes, yeah, mostly I give tramadol only.
Ma'am,
ma'am,
how about
tapentadol with buprenorphine
Pardon?
can be given, ma'am, instead of tramadol.
Yes, yes, tramadol. Instead of tramadol, tapentadol can also be given.
Thank you.
Yes.
ma'am, anything add on gating mechanism or regarding pain management?
Gate control theory.
Yeah, ma'am.
Just a minute, sir. So for gate control theory is this in the dorsal horn, it is like a gate, they say. So in the simpler words, on one hand, we have the pain impulses coming, that is through C and the A delta fibers. On the other hand, we have the touch and the other non-nociceptive, the impulses coming via the A beta. Okay, so gate control theory in simple words, they say that if we stimulate the A beta more, then the gate will close for the A delta. There will be competition for the gate. So more impulses will go through the A beta will go more through the gate rather than the A delta and C. So this is the basic mechanism behind many of the pain management modalities like spinal cord stimulation and our TENS, acupuncture. All these have actually some basics in this gate control theory of pain. That is, stimulation of A beta fibers will close the gate for A delta and C. The gate will be open more for A beta. And somebody was asking, how can we manage nociplastic pain? So nociplastic pain is basically an amplification of the pain processing, right? So here we have the main culprit is sensitization. So what we can do is, as I told in that picture, NMDA antagonist, ketamine infusions. Methadone has some role because it has got NMDA antagonistic activity. So methadone can be given if it is cancer patient. because opioids in non-cancer, we have some restrictions. So otherwise, we can give IV lignocaine and ketamine infusions. And we have to optimize this agents that tackle sensitization, like gabapentinoids. Then we can give this what do you call TCS, tricyclic antidepressants, SNRIs, selective noradrenaline reuptake inhibitors, because they have role in inhibitory modulation. Okay, so all these agents we can optimize along with IV lignocaine and ketamine infusions. That is how we manage this nociplastic pain. Anything else?
Ma'am, how about ketamine sublingual route, which some centers use?
Yes, sir. I don't have experience with that, sir. I give lignocaine, ketamine infusions only. But yes, it is there. It can be given. Ketamine nasal spray is also available in the Western countries like this.
Excellent. Please, if anyone has any doubts, please ask, ma'am, because it's an open session and there's no need for hesitation. You can, of course, clear our doubts then and there.
Ma'am, only in chronic conditions we'll point out for sensitization, right? Or in acute states, you don't think about sensitization.
No, acute also. Actually, there is one study that says that the sensitization starts within 6 hours.
Okay.
Okay.
So how will we clinically differentiate between that?
Clinically, see, our motto should be to see there is something known as sensitization, and if that sets in, and sensitization is not like a switch on or off. Even after the sensitization starts, as the time elapses, no, more and more sensitization becomes more and more. It's a vicious cycle. So even then, so if you ask me, in post-operative cases, if your patient is going for CA patient is going for a surgery, the post-operative pain management is very important, because post-operative pain is severe, and that is the study which I told you that was conducted in post-operative, and somehow they found out that with the biochemical mediators, etc., they studied, and they found out that even within 6 hours of in the post-operative scenario, the sensitization starts, because that is severe pain due to the nausea stimulation, post-operative pain. But in other pain scenarios, it may take some time for the sensitization to set in. So how do we know that is poor response to the conventional analgesics? Once sensitization sets in, the pain becomes very difficult to manage, and there will be poor response to the conventional analgesics. So we have to start the drugs that tackle sensitization also.
And usually, ma'am, what we have learned is that when you have a constant stimuli, there is downregulation of receptors, and the effect reduces. But in pain, it's just the opposite.
Yes. Okay. And this happens with opioids. Since that you pointed out that in nociplastic pain, somebody was asking, how we manage nociplastic pain. So not just nociplastic pain, in many neuropathic pain conditions and all, we may, once we are very confident in giving morphine, we may just go about and give morphine. Now the patient is having severe pain, not responding to analgesics. Why don't you start morphine? I am very confident in moving up the analgesic ladder. But what happens is the endogenous opioids are already increased. So the opioid receptors are downregulated. So this happens in many chronic pain, especially the ones with sensitization, fibromyalgia, neuropathic pain. So what happens is then even if you give opioids, the pain will not respond to that. It can even worsen the hyperalgesia component. So that happens with opioid receptors. But other than that, what happens in the periphery at the level of nociceptors and the dorsal horn neurons, this NMDA receptors, all these are upregulated, and it will be a vicious cycle. As this goes on, this will increase. And somebody was asking, is there any role of ketamine in non-operative? Yes, yes. In Pallium India, sometimes we give ketamine infusions for cancer pain also, severe cancer pain also, not responding to any other analgesics. We understand that sensitization has set in. We can try ketamine infusions, but the evidence is less. The evidence for ketamine infusions is maximum for neuropathic pain, then post-operative, then fibromyalgia. For other conditions, the evidence is less.
Ma'am, how about paracetamol infusion for central pain?
Sir, evidence base also in practically also, I don't think there is much benefit, but NSAIDs work, because as we have shown in that central sensitization and peripheral sensitization picture, there is definitely a role of COX-2 prostaglandin. So NSAIDs work, at least in short term. It definitely works well for sensitization, but paracetamol, I don't have much good experience with that. If you have any experience, you can add to that, sir. How do you tackle sensitization?
I know sometimes if the patients don't respond much to the opioid or morphine, and sometimes it happens that we give paracetamol infusion and patient feels better. I mean, I think that's why I asked, because central pain, maybe that's why.
Okay, sir. Actually, short-term benefits may be there, but if you look at the pathway of sensitization, paracetamol does not have much. But I also do that. Ultimately, when nothing, like a patient is having severe pain, I have given morphine. Patient is not having relief, I also give paracetamol infusion regularly in my center. But if sensitization is the culprit, then NSAIDs and all the other things work better.
Okay, thank you, ma'am.
And sometimes in cancer pain, what I have felt is there is a good amount of musculoskeletal component to that. Even if the pain is originating from the viscera, the patient may have bone mets. When the patient have extensive bone mets, the muscles will become weak. The supporting structure, the framework for the bones, that will become weak. So this musculoskeletal component that benefits much from paracetamol infusions. The patient will have an overall improved response to with paracetamol infusion.
Okay, ma'am, thank you. We are almost running out of time, ma'am. There is one more question by Dr. Sunish. Is there any role for ketamine in non-operative settings?
I already explained that. Ketamine evidence is maximum for neuropathic pain, operative, and fibromyalgia. Less for other cases, but practically we have given that.
Okay. And is there any evidence for tramadol infusion?
Evidence for tramadol infusion in
non-operative settings, maybe?
No, definitely. Tramadol we are prescribing daily to our cancer patients. And if you ask regarding sensitization, tramadol has a role. Why? Because I actually, I understood that most of you were feeling, it might have been going above head. So I skipped that slide. There is something known as inhibitory modulation. No? So this inhibitory modulation works through noradrenergic neurons. So tramadol has dual action. No, tramadol inhibits the reuptake of noradrenaline. So tramadol, it activates the descending pathway, descending inhibitory modulation. Tramadol activates that. So tramadol has a role in modulation. It activates the inhibitory modulation of pain. So tramadol has a role in central pain, definitely. Tramadol has, NSAIDs has, all our gabapentinoids, TCAs, SNRIs, they all have a role in central pain, where that is tackling modulation of pain, sensitization of pain. Okay. But opioids don't have much role. Paracetamol also don't have much. Why opioids doesn't have much role? If you look at the pathway, opioid receptors are there in the dorsal horn everywhere. But this happens often, that is opioid receptors are down-regulated. In many cases of central pain, opioid receptors are down-regulated. That is why opioids doesn't have much role.
Actually, my question was, if a patient is reluctant to start on morphine infusion for a severe pain like in pancreatic pain, can we give tramadol continuously as an infusion?
Your patient is having? I didn't get you.
Severe pain like pancreatic pain.
Okay.
And he is reluctant to take morphine as an infusion because he came with severe pain. So sometimes for the first time, he may not be ready to start on some morphine infusion. So can we give tramadol as continuous infusion?
Sir, I don't have experience in giving tramadol as continuous infusion. I give as an infusion over 20 to 30 minutes, or sometimes in frail patients up to 1 hour, and I repeat that every 6 hours. Or sometimes in severe pain, we can repeat 4th-hourly also. But if anybody has experience, I am willing to explore that. But I don't have any experience in giving continuous tramadol infusion. But what I do is I give tramadol and paracetamol intermittently, because every 2 to 3 hours, patient will get 1 infusion. If, like you said, the patient is not willing to start fentanyl or morphine, strong opioids, then we can give tramadol and paracetamol infusion alternatingly. That's what I do. Practically, that's what I follow. Like I gave 6 a.m., morning 6 a.m., I'll give paracetamol. That infusion will end at 7 a.m. 9 a.m., I'll give tramadol. Again, 12 a.m., I'll give paracetamol. Again, 4 p.m., I'll give tramadol. So every 2 to 3 hours, the patient will get an analgesic round the clock. But if you don't write that clearly, what the sisters do is, if you write paracetamol 1 gram IV TDS and tramadol 100 milligram IV TDS, what our sisters do is, they will give both at the same time. 6 a.m. tramadol paracetamol. Patient will have excellent relief for next 2 to 3 hours. By 10 a.m., patient again is in severe pain. Nothing is there. Everything is exhausted. So you have to instruct your patient clearly, intermittently, give it regular time intervals. The patient should get an analgesic every 2 to 3 hours. So this is what I do if the patient is not on morphine or cannot give morphine.
Okay, ma'am. Thank you, ma'am.
We are almost reached time. Is there any question? Maybe we can take one more question, if there is any, or else we'll wind the session. Okay, I think there are no more questions. Okay, there's one more chat. Okay. There is a feedback form that also, please, everyone, please give the feedback forms also. That is a link is there in the chat box. Okay, thank you so much, Dr. Vineetha, for the excellent presentation, and the participants also were very involved in the session. And we have the take-home message like, believe the patient. Whether if the patient is complaining of pain, consider all the 4 domains of the total pain. And under treating patient, that's a very problematic thing, because 90% of the patients with advanced cancer have severe pain, and we have to consider, like, we have to take measures so that no patient should die or live in pain. Okay, so thank you everyone for the session, and next week we will meet the same time. Good night.